In this next part of the compact echo course, we will talk about also very important views, the subcostal views. While the subcostal views you can reach, of course, subcostally, you need to place the transducer below the xiphoid or the rib cage and scan the heart from below. Always remember, the liver is your window to see the heart even better. There are no bones, no lungs who can block your field of view. The marker is oriented to the left of the patient if you're looking for the subcostal 4-chamber view, of course in a cardiac preset with the cardiac transducer as well. The patient is in a supine position and it's an optimal view for the intensive care unit, emergencies, emergency departments, obese patients, also COPD patients. You can use this view if the left lateral position is not always possible or you simply have bad image quality in the other views. This is the best view for pericardial effusion and also to measure the right ventricular wall thickness. It should be a part of all of your echocardiographic exams, and basically you can perform almost a whole exam from this position. Important, of course, is the transducer handling to know and to visualize the standard views. So starting off with a subcostal 4-chamber view, you see the left ventricle, the right ventricle. Here you have the right ventricular free wall, sometimes inferior wall to see. Here is the space which can show pericardial effusion, the right atrium, the left atrium, and of course also the valves. In the normal B-mode imaging, this is how the heart should look like. This is the right ventricle. Here you have the wall of the right ventricle. Here you can measure the thickness. You don't see any kind of pericardial effusion in this patient over here. This is the tricuspid valve, the septal leaflet, and the anterior posterior leaflet, depending on the angulation. This is the left ventricle. There's a little bit of foreshortening, of course, from the subcostal approach present. The mitral valve, anterior and posterior leaflet, the left atrium, seen here as well. So when you're below the xiphoid process, you can use, as said before, the liver as your acoustic window. So you will have sometimes superb image quality by means of echocardiography. In the subcostal 4-chamber view, you should see the 4 chambers of the heart. Sometimes it's not that easy to see immediately. It could be also a 5-chamber view, or it could be a little bit of rotation. Then it would look a bit different. But overall, you can see, at least to a certain degree, how the left ventricle and how the right ventricle works, and if there are some severe valvular pathologies. Furthermore, this is the optimal view due to the angulation towards the transducer to visualize the interatrial septum and if there's probably some shunting present. Furthermore, as said, you can evaluate for pericardial effusion. A pericardial effusion is actually present when there is 4 millimeters of echo-free space, so free fluid, around the right ventricle in and diastole. So that's very important to really differentiate a normal collection of fluid from pericardial effusion. This is now such an example where you see pericardial effusion all around the right ventricle, also the right atrium. With the left heart, it's harder to see in the subcostal approach, but the right ventricular free wall, so the right ventricle overall, is the low pressure chamber. So if there's any hemodynamic relevance, you would see it primarily in the right heart, so first the right atrium and then also the right ventricle, and it would be compressed during end diastole. This, in this case, is not present, but this is a case of pericarditis. You see here the right ventricular free wall, tricuspid valve, mitral valve, the left ventricle, and the atria as well. In this loop, you do see a dilatation of the atria. You see mitral annular calcification, also a small degree of pericardial effusion, and a reduced right ventricular function. Be aware that from a subcostal approach, you always have to be careful about the angulation and the actual function you might see in the ventricles. So there are some pitfalls, but still in a clear case, very often you will figure out what right ventricular and also left ventricular function looks like. In this case, you have a reduced right ventricular function. You can see it over here, even though it's an image where the transducer is being tilted and moved a little bit. You can also see that the atria are definitely enlarged. You see here the aortic valve to some degree. So approximately here is also a 5-chamber view, a subcostal 5-chamber view. And you do see that the left ventricle at least appears dilated and definitely shows a reduced function. You also see this bouncing motion of the septum, which also points towards elevated right ventricular filling pressures. So overall, only with this one view, you can get a lot of information about this patient who actually is not feeling that well and was decompensated. Another important structure to differentiate is epicardial fat. So here we have free fluid and another thicker layer. This specific patient actually had a Dressler syndrome. So you see this pericardial effusion, it's definitely not large, but this patient had an intervention, cardiac intervention, and after 3 weeks presented with fever, chest pain, fatigue, and also dyspnea. So in combination with this imaging, the diagnosis of a Dressler syndrome was established, and after treatment, the patient felt way better in a very short period of time. In this case, you do see a patient with pulmonary hypertension. You do see that the left ventricle is rather small compared to the right ventricle. If that would be a short axis, that would also be called D sign. So also in this case, you see this shifting motion of the interventricular septum towards the left ventricle away from the right ventricle. In this case, the right ventricle is the high pressure chamber, also compared to left ventricular pressure. So the right ventricle is dilated, definitely reduced in function. You can see it here that the overall contractility is reduced, and there is a severe case, I would say, of right ventricular hypertrophy. So you see the right ventricular free wall where you also would measure, and the right ventricular free wall is almost as thick as the interventricular septum, so around 8 to 9 to 10 millimeters. So it's definitely thickened. Here you have another rather interesting case. This is a patient with coronary artery disease. How can you assume that this is coronary artery disease? Well, here you see the basal parts of the interventricular septum. They're definitely thin and hyperechogenic, and of course, in the overall echo, you saw wall motion abnormalities, scars, and also this patient had a history of coronary artery disease and also had a STEMI just a few weeks before. Now you see in this patient an acute coronary syndrome, and overall left ventricular function was probably 30 to 35%. What you cannot optimally see in this view is that there's also a mitral clip present, so you cannot really see this, but you see a small iatrogenic atrial septal defect. You see here is a bulging of the interatrial septum, so this is the left atrium, the right atrium, and the septum is pushed towards the right atrium, which is per se a situation which can occur because overall left ventricular pressures and left atrial pressures are higher compared to the right heart. But what's quite intriguing is that there is also this small iatrogenic atrial septal defect because you need to perforate the interatrial septum to place the mitral clip. Furthermore, a quite interesting finding is this structure here. So this is most likely a Eustachian valve. A differential diagnosis are arete chiari, so just anatomical structures which you can see in echocardiography. Going back just for a second to this atrial septal defect, you see that there is a shunting, so this small flare and color Doppler from the left atrium with the higher pressures, also explained by coronary artery disease, and this case of heart failure with reduced ejection fraction from the left atrium to the right atrium. To even more optimally visualize, you can even use color M mode. So it actually doesn't give you that much of additional information by means of how large the atrial septal defect is. We already can assume that it is not very large, also because it's an iatrogenic ASD, so this won't be a problem by means of volume overload, but you can see quite nicely how the shunting looks like. So this is the small iatrogenic ASD in color M mode.